Good morning. Good morning and welcome, and thank you for joining me today. I'm Dr. Linda Ferris. I'm one of the medical oncologists at Northwestern Regional Medical Group, working out of the Warrenville Cancer Center and Central DuPage Hospital. We're filming this morning at the Northwestern Warrenville Cancer Center, and we're going to talk today about lung cancer. This is compliments of Living Well, who has offered a host of support services for our patients and their families. They're offering multiple programs and making changes as needed because of the COVID restrictions, but again, reaching out and making programs available to you and your families as you are dealing with a difficult illness. So I'm going to talk a little bit about lung cancer, and then we will open this up for comments and questions, and I encourage you to be submitting things, and hopefully we'll have time at the end to be able to answer questions and to address concerns that you may have. So the first thing about lung cancer is the statistics, and I think they are very sobering. Most people probably are aware, but lung cancer is the greatest cause of mortality among all cancers. So it accounts for about 25% of all cancer deaths. And this is worldwide. Fortunately, in the United States, we have started to see a decline both in men and women in terms of lung cancer incidence and mortality. And this is primarily due to the decrease in tobacco use. But again, worldwide, we are not seeing the same statistics. And unfortunately, it is still out there and still very concerning as far as the extent of lung cancer. So we know that lung cancer risk factors, the primary one is smoking. I don't think that's a surprise to anyone, but other things that people may not think about is radon. And these are things that you may want to check your home for. And any type of exposure that is a risk factor for cancer, and particularly lung cancer, happens over a long period of time. It is not just a short interaction. So these are things that you can make interventions, you can make a difference. And as far as radon goes, you may want to be checking your homes to see if that may be a risk factor for you. Other risk factors that people may or may not think about is occupational exposures, and these are fumes or dusts or asbestos, things that again are inhaled or come in contact with the lungs over a long period of time, which causes chronic inflammation and irritation that can lead to increased risk of cancer. So we know that the statistics are sobering. We also know that the vast majority of people come to us with cancer that has already spread outside of the lungs, so as metastatic lung cancer. When cancer has spread from where it started, by definition, it is not curable, but it is treatable, and we still hope to contain it and to help people live longer and to live better. But it would be nice if we could find cancer at an earlier stage and make it more treatable, and at that point it is potentially curable, although we still know, particularly with lung cancer, that there is a significant risk of recurrence even after we have gone through the earlier stages of treatment for lung cancer. So this begs the question, what are the presenting symptoms that one may have? And unfortunately, they may be very subtle symptoms, such as cough, weight loss, fatigue. It may be something that is picked up incidentally on imaging that may be done for another reason. It's not uncommon for people to be in the emergency room for some unexpected or unrelated illness. They have a scan done, and all of a sudden something shows up, which may down the road lead to a diagnosis of lung cancer. But we do have a way to find lung cancer at an earlier treatable stage. And this has been out there for a few years, although I'm not seeing the excitement about lung cancer screening. So we have screening for other types of cancer. We have mammograms that can pick up breast cancer at an earlier stage. We have colonoscopies that can pick up colon cancer at an earlier stage. We also have lung cancer screening for high-risk patients that can potentially pick up lung cancer at an earlier stage. and allow us to treat it and hopefully at a more curative stage. So this is done with a CT scan done without contrast. It's very quick, it's very easy, and it's done annually. The population that we're looking at are the higher risk people who have had a risk of lung cancer based on their smoking history. So again, we know that that is a known risk factor, and we're looking for people between the ages of 55 and 77 who have had a significant amount of tobacco use, whether they are still smoking or have quit within the past 15 years. This is something to discuss with your primary care physician to see if you are appropriate candidate for the screening. And again, this is a dialogue that you'll have with your primary care doctor or your pulmonologist if you have a lung doctor, to put you in line for lung cancer screening. And looking at the results, if we do find a cancer, hopefully we find it at an earlier, more treatable stage before you ever have symptoms. And we know that it can decrease the risk of dying from lung cancer by 20%. That's huge when you look at the number of people diagnosed with lung cancer. So that's screening. That's looking at, can we find lung cancer before anyone even has any symptoms? And again, looking at the higher risk population. What if you do have a diagnosis of lung cancer? What if we find a spot in the lung or elsewhere that may be concerning for lung cancer? What's the next step? So the gold standard, or the traditional way, is to actually sample something. So although we can look at a scan and be very concerned and say, wow, this looks like it's lung cancer, we can never really diagnose cancer until we actually have some cells that we're looking at under a microscope. And again, we may do this by a bronchoscopy, by someone looking down into the airways and sampling something, either lymph nodes or a tumor that may be there. A more recent test that we may be able to use if we're suspicious of lung cancer is we may actually look at a blood test or do this in conjunction with actually sampling a tumor that may be in the lung or elsewhere. Tumors can shed cancer cells in the bloodstream, and it may be a quick way for us to find cancer cells. It's less invasive than going down into the airways or going through the skin, either the chest wall or into some other area. And it may give us more information besides just a diagnosis. So can it diagnose lung cancer? And can give us more information about the lung cancer cells. This is referred to as a liquid biopsy. And again, we're talking about getting cancer cells from the bloodstream. Those tests can take up to a week to get back, but sometimes it may even be quicker than scheduling someone for an invasive procedure. Sometimes this is used at the same time or in conjunction with another invasive procedure so that it gives us two chances to get the diagnosis as quickly as possible and to be able to find out more information about your cancer. So if there is ever a concern about cancer, any kind of cancer, but obviously we're talking about lung cancer, we want to be able to go after that diagnosis quickly so that we know what the diagnosis is, so that we can work on getting all of the information about the stage, what is the extent of the cancer, what do we know about it, and how do we treat it. So once we have a diagnosis of lung cancer, there are two main types of lung cancer that we know of. The majority is called non-small cell lung cancer, which is about 85% of lung cancers. The other is less frequent, about 15%, is small cell lung cancer. These are very old terms, obviously not very creative, but it really defines a different histology, a different behavior of the lung cancers. For the majority of people, like I say, it is non-small cell lung cancer. The other one that's out there that we don't talk about too frequently is mesothelioma. which is also treated differently. There are other types of cancers as well that can be found in the chest that have a smaller percentage. We won't even mention those today. So again, the majority are non-small cell lung cancer, and within that category, we also have three main categories: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. So we try to define these cancers as precisely as we can because that may impact treatment. We know that certain treatments, meaning chemotherapy, may work differently for different types of cancer. And so we try to tailor the treatment as specifically as we can because we want to use the best treatment that we can for the treatment and get the best results. We try very hard to find out other characteristics about your cancer. So we will, in most cases, send your tumor or biopsy results away for more specific testing, and this is mutation testing, or what we call next generation sequencing. And what we're looking for are specific mutations in your cancer that may be driving it to grow. And if we can find one of these mutations, we may again find a specific treatment, a specific type of chemotherapy that works specifically with that mutation. So it may provide information about treatment that we already have available. It may also put you in line for a clinical trial specifically for a mutation that is driving your cancer to grow. So again, once we have a diagnosis of lung cancer, we have small cell cancer, which again is a different category we're not talking about today, non-small cell lung cancer. If it is an earlier stage, we may look at surgery alone. We may look at surgery followed by radiation, or we may look at a combination of chemotherapy, radiation therapy, and surgery. Those are all curative intent, and again, it depends on the stage at diagnosis. If the cancer has already spread, we are primarily talking about chemotherapy or immunotherapy, therapy that goes through an IV that essentially goes to all places, usually except the brain. But again, every place the blood goes, we want the systemic therapy to go as well. When we're talking about systemic therapy, and that's essentially either chemotherapy or immunotherapy that you either take in terms of a pill or that goes through an IV. We have traditional chemotherapy, and these are drugs that most people associate with cancer, although I will say we have come a long way in how we treat the side effects that go along with treatment, and people are pleasantly surprised that they do not have the side effects that they expect. We also have targeted therapy that we are now starting to use in an earlier setting, even before it's metastatic. So again, if we find a cancer that has a specific mutation and somebody has already had surgery, but we're still concerned, may there be some cancer cells that are left behind that we want to take care of so that they don't have a chance to grow. Sometimes we will give traditional chemotherapy for a few cycles, usually 4 cycles. But the most recent data is if you have one of these mutations, we may be giving you a chemotherapy pill that you take for a couple of years that decreases the risk that the cancer will come back. And again, this is just hot off the presses news that was just reported in our most recent oncology meeting in May of this year, and this is practice changing. We also have immunotherapy, but at this point, immunotherapy is primarily used for people where the cancer has already spread. And these are drugs that people have heard of or see advertised on TV. Keytruda is a brand name. Nivolumab and Opdivo are a brand name. But we use the generic names, which you probably wouldn't recognize. But there are also other immunotherapies that we use as well. Sometimes we use it even before the cancer has spread. So we have an arsenal of systemic therapies that we use, and it's so important to get to the right person, to the right program, to make sure that you have someone who is up to date on all of the available testing and nuances that are associated with lung cancer. Again, earlier treatment, try to get the screening if it's appropriate for you. If there is a diagnosis of cancer, we want to make sure that we have all of the information up front. We want to make sure that a patient is treated appropriately with all of the modalities. We generally, most programs have a multidisciplinary tumor board. We do as well, where we discuss patients and treatments that may be most appropriate for the patient. We talk about clinical trials that also may be appropriate for the patient, and get the patient into treatment as quickly as possible. And again, using the support services that we have at the cancer centers, using the support services of Living Well as you go through treatment, so that we understand that this is a life-changing diagnosis, but we want to make sure that you also have everything that you need as you are dealing with this diagnosis. So we can open this up for questions or comments. This can be very complex, and unfortunately we only have a few minutes to discuss this, but I'm very happy to answer questions and concerns that you may have. And I'm not sure the best way that we discuss this.
Sure. Dr. Ferris, regarding the screening for lung cancer, do insurance companies cover the cost for this screening?
So the question is, does insurance companies cover the cost of lung cancer screening? And at this point, this is a work in progress. However, I will say that the National Services Task Force has said that this is an appropriate screening modality. Medicare is covering this, and insurance companies are covering it. And if it is not, there is a mechanism in place so that the individual individual patient is not left holding that cost. But again, if there's ever questions, we always make sure that is addressed before the screening is even ordered, or before the screening is even done, so that it's taken care of and there are no surprises either for you or for the health facility. But again, most of the people, again, age 55 to 77 are Medicare, and Medicare, it is covered with Medicare.
And regarding genetics, if a patient has somebody in their family that has a history of lung cancer, is there a component that it could be a genetic link?
So the question is there a genetic component to lung cancer? There is not a genetic component seen as frequently with lung cancer, but there can be. And again, you see the genetic cancers most frequently in things like the colorectal cancers, the breast cancers, the gynae cancers. Lung cancer, again, the more frequent risk factor is behavioral, or things that we talk about like smoking and occupational exposures. There are certain mutations, and this is where we talk about the genetic mutations that can be seen that run in families. One of them is what's called the EGFR mutation. This is usually seen in people who are non-smokers, and it can be seen in family clustering. So again, it's not the first thing that we think of with lung cancer. Again, the most frequent thing that we see are the other risk factors. But yes, it can run in families, and like I said, it's usually these specific mutations that we see. Now, we don't necessarily do genetic counseling. We aren't at that point with lung cancer. And that's primarily due to the numbers of people that we see with lung cancer, and this being a very smaller proportion, but I would just say that if there is lung cancer in the family, you should be aware of potential symptoms you may have, and again, just have an ongoing relationship with your primary care physician, that if it's appropriate, if you have symptoms, whatever, that somebody is watching you very closely and guiding you in the right direction.
With a lung cancer diagnosis, what's the value of obtaining a second opinion, and is it recommended?
So as far as a second opinion goes, for lung cancer or any kind of cancer, I think we're very confident with what we offer here, but I think cancer itself is a life-changing experience. And I would encourage anybody, if there are questions or concerns, that you feel comfortable getting a second opinion, wherever that may be. And again, you would find that many of the things that we talk about, you will hear again. And sometimes if somebody presents it in a different way, it may be that you understand it better. That may open you up for clinical trials that may be offered at a different facility that we wouldn't have here. But I would expect that most of the treatment should be standard, because we go by national guidelines as far as screening, treatment, follow-up. How do we follow patients after a diagnosis of cancer? But I would encourage you that if there are ever questions, that you go for a second opinion. Many times people do go for a second opinion. They hear things, they come back, and they're comfortable, but they've heard it, they've looked elsewhere, and we have people coming to us as well for second opinions. And again, as long as you get the information that you need, that's the important thing. Physicians we don't get our feelings hurt if you go for another opinion. I think that's recommended. You hear it on the radio, you hear it on TV. Go for it so that you are comfortable, but you do it in a timely fashion. You don't delay treatment, so that you are, again, ready to go forward, and that you are going forward where you feel most comfortable where getting your treatment, because it's a long-term relationship with you and your physician.
Talking about starting treatment once a diagnosis is made, how quickly does a patient need to make a decision regarding treatment?
The question is, how quickly do we need to start treatment when there's a diagnosis of lung cancer? I think part of it is an emotional thing, and that can go in either direction. People many times are blindsided by a diagnosis. It's something that is totally unexpected. And we guide people through very quickly to get a diagnosis, to get the staging, to talk about treatment. This is done within a very short period of time. I know in our program, we strive very hard to get people in within 48 hours of a diagnosis, or if there's a concern about diagnosis, because people want answers. They don't want to delay. And as much as they don't want to know, they want to know. So although cancer itself does not grow as quickly as you may think, except certain types of cancers, I will say small cell lung cancer is a different animal, and it does grow more quickly. Generally, you do have a little bit of time. However, there's a lot to do, there's a lot to digest, and I would encourage you to go through the steps and understand what the steps are and do it quickly. And I think that's going to put your mind at rest as well, that you are doing something to take care of the cancer. It's putting you back into control, as well as treating the cancer and knowing that you're doing something. So again, you don't have to do something tomorrow, but I would encourage you to do things as quickly as you can, just to put you back in control and to make sure you're doing the right thing. If it takes a week, if it takes a couple weeks, in the big picture, it's really okay. But again, the more information we have, the quicker we can do things, the better you feel about just getting going with treatment.
How will a patient know if a treatment is working?
The question is, how do we know if treatment is working? And sometimes this can be very frustrating, because you don't get the answers as quickly as you want. You may be going through treatment, particularly the earlier stage treatments. Obviously, if you go through surgery, the thing that you know about is that everything that was visible, everything that we could see was removed. The next CT scan, which is primarily how we monitor people, will be a couple months down the road. If we're doing chemotherapy with radiation up front, it's going to take several weeks, usually a month to 3 months after treatment, before we would even do our first imaging to know if there has been an effect. And understand that during that time you were getting treatment, there's no reason to expect that things are growing. If there would be any new symptoms, obviously we would get imaging done quicker, but it takes a couple of months, a couple weeks to a couple months before we do imaging. If cancer has spread from where it started, if we're treating metastatic cancer, we usually do scans about every 2.5 to 3 months. That allows the treatment that we're doing to work. And that also gives you a little bit of a breather so that every time you turn around, we're not doing another scan. Scans are important. Many times I will show people what their scans look like, what they look like compared to their previous scans. Cancer changes, but not as quickly as you think. So even in a couple months' time, we may see things only change a couple millimeters, or they may stay stable. So that's why we try to move things out at about 2.5 to 3 months. We can also tell if things are working by gauging symptoms. Are your symptoms better? Is the blood work better? So there are other things that can give us an indication if things are working even before we do the interim scans. After someone is cured, after we've gone through curative treatment, we still watch with imaging. At that point, the imaging is lengthened out a little bit so that interval is every 6 months for 2 years. And then if everything looks good at that point, we still continue CT scans on an annual basis.
And last question, knowing that we're monitoring using scans and frequent follow-up, is there anything a patient should be watching for themselves?
The question is, what should an individual be watching for in the interim between scans? My advice, and I always tell people who are coming to me, is if there's any symptom that lasts, call us. Because cancer symptoms can be very subtle, and it may not be anything that you would equate with cancer. And yet it may get our attention much quicker than it would get your attention. So of course we watch for things like new pain, new shortness of breath, new fevers. All of a sudden you have unexpected weight loss. Something has changed, your energy level has changed, new headaches. But I also hate to give people just a list of symptoms to watch for, because if something is not on that list, they're going to say, oh, you didn't tell me that. So I always tell people, if there is ever a question, ever a concern, contact your primary care physician. You can always call us, because I would rather know about it. I would rather have you come in. If there's something that is not related to your cancer, okay, that's good. But if it is something, it may give us an early indication of something that you may not expect may be associated with your cancer. So any symptom that lasts, anything that is new, any change, we want to know about it. So again, I would just encourage you to always have a good relationship with your primary care physician or with your oncologist. Thank you very much for joining us today. Thank you so much for Living Well to provide this program. We continue to do weekly programs on different oncology subjects to keep you in the loop and to keep you connected with us and to keep you connected with Living Well. If there are programs that you would like to see, if there are questions that you have, comments that you have, we encourage you to contact Living Well. They have been a great support for us, and we want them to continue to support you and the needs that you have. Thank you.